Hello, and welcome to learning a little bit more about how we can help our most vulnerable to become our most victorious through OraLase and BabyLase, where we take away the pain and turn on the brain. When you ask why, what if, and why not, you force yourself to explore what's possible and not just what is. So I've been in the position of asking all of those questions, and I'd like to introduce you to myself. My name is Dr. Angie Tinholder. My disclosures are that I'm the president of the Synergy Academy, the Alpha Interface Academy, the Integrative Solutions Academy, and Synergy Dental Solutions, as well as being a general dentist of over 30 years, a fellow in the Academy of Craniofacial Pain, board certified in craniofacial dental sleep medicine, where I'm currently serving as the president of the APC DSM, and I have my fellowship in the Academy of General Dentistry. But more important than all of those things are my why. I was a patient. I'm a former chronic pain patient at 35. It all started, and now I can happily say that I'm on the other side of that. I'm a doctor. I'm a mom of 3 kids who all needed my help, and I'm a wife. So, what if others could benefit from learning from my experiences so it might be easier for those who might follow? I'm an instructor for the Synergy Academy, where we teach ALF therapy and OraLase, and I was the one who developed BabyLase. I'll tell you a little bit about that story later. But I'd like to first start with a question. Why do some people need more help than others? Why did I develop chronic pain? Why did my daughter and my son have issues? There's a combination of nature and nurture. We all know that. And then we're all struggling to figure out how form and function go together as dentists and orthodontists and medical doctors. And then there's always this spectrum, this pendulum that goes between conventional thinking and alternative or progressive thinking. I'd also like to ask the question, what are our current limitations in helping our patients and our families? Einstein said it best, sometimes the only thing that interferes with learning is education. Some of us have mindset limitations where we learned something and we felt that it was our truth, and we're kind of stuck there, whether it's airway structure, tongue tie, surgeries, etc. Sometimes there's a tribe mentality that goes along with that training. Some of us might have limitations to access to technology, the limitation of politics, and obviously there's always financial considerations. One of the things that we are asked to do in dentistry is to first do no harm. We're all normal people with normal jobs who are trying to do our very best to make a difference in the lives of our patients and their families, as well as our own. So why not do everything that we can as soon as possible to help as many people as we can? And as many differences as we all have, there's a few things I think we can agree on. And one of them is the Dunning-Kruger effect, where we first got out of school as, budding new dentists. When we first started, we didn't know anything, right? We were like at this novice level, huh? And then when we graduated, we're like, we're doctors. Once was blind and now I can see. And then we got out of school and we're like, well, there's a little bit more to this than I thought. And then we experienced more challenges and thought, wow, are we ever going to understand all of it? Then once we get farther along in our process of the knowledge in the field, it starts to make sense. But the true experience level of being, quote, the expert is to say, trust me, it's complicated. The other thing that we can agree on is the one thing that 2 doctors can agree on is the third one could or should have done something differently. As professionals, we are constantly exposed to concepts that are thought up, but not always thought through, including the risks that we take by doing aggressive and irreversible procedures, the unwillingness to embrace the principles that are, quote, operating systems as humans, is founded in nature and eventually explained by science. This aspect of human nature of choosing oversimplification over authenticity is very common, and it's easy to pick the low-lying fruit, but that's not what I'm going to be talking about today. Because what happens is just like the fish as they got out of the aquarium in the Finding Nemo movie, and they rolled their way out the dentist office window and into the ocean, and they got there and they said, well, now what? And would it surprise you to know that many of the key opinion leaders in the field of performing surgical tongue tie releases aren't really sharing some of the information that might be critical to the success or failure of these procedures? One of the professional healthcare surveys that was done recently on the complications and misdiagnosis associated with infant sternotomy concluded that there's a lot of complications and misdiagnosis that we should be working together with a functional team to support these families. We need a little bit more work to figure out what our true answers are, because the most expensive liquid in the world is a tear, and we should be really thinking as we're going through this process. And as a healthcare community, we have witnessed throughout time some pretty preposterous ideas that proved to be false after being widely accepted as true. We've also heard some brilliant ideas that were initially dismissed as being too good to be true and are now considered to be the standard of care. We've had instructions on some fairly limited ideas and concepts that were made to sound like they were comprehensive. And then there's always a contemplation of these fascinating concepts that sometimes seem to be out of our reach due to limitations of what we can comprehend, as well as our scope of practice. We have all had our guessing machines challenged when we thought that we provided the right service, yet experienced the wrong outcome. Some of those people that also had their guessing machines challenged were Dr. Nikki Mills, which, as an ENT doing tongue releases, she had a similar experience when assessing the results from her release procedures and discovered that the tissue composition of the floor of the mouth is actually composed of fascia and not a discrete quarter band. There's Dr. Derek Nordstrom, who developed the mandibular advancement device and was very aware, even from the very beginning, that it was not the cure for sleep apnea. Dr. Gabor Mate realized his symptoms, as well as those of many of his patients, were caused by early childhood trauma. And Andersoni's discovered recently in 2023 that the pathophysiology of sleep apnea is strongly influenced by neurotransmitter depletion and not exclusively as a structural collapse of the airway, or what we refer to as a choke point. So this is a picture of Dr. Nikki Mills. She is a pediatric ENT, and her research was done on postmortem patients, and she did the dissections of the floor of the mouth anatomy and concluded that the lingual frenulum is not composed of connective tissue fibers that have an anterior-posterior orientation, nor is it a discrete band or cord, as described in the literature. But she found out that these fascial fibers that form the frenulum have a basket weave orientation as they cross the midline. And therefore, her statement is the classification of a, quote, posterior tongue tie, as it's referred to, is based on the construct of a midline submucosal band, was not supported by her dissections. This is a drawing that represents what she was trying to communicate, that we cannot visually identify what is in that submucosal fold. The red line represents mucosa, the green line represents the fascia that's being pulled up in that fold, and then there's the muscle, the genioglossus underneath it. Her research showed that by visual assessment, we absolutely cannot be sure what it is that we are cutting through and the risks associated with that. And this is her research, and this is the link to her podcast that talks about some of her concerns with the amount and types of tongue releases that are being performed. And this is Dr. Derek Nordstrom, who was the inventor of not only OraLase, but ALF therapy. While he was developing OraLase as an adjunct to services that we all need help with, he assessed all these different components of health. Too many to read through, but basically acupuncture points, hypnosis, the way the brain works, primitive reflexes, the relationships of our oral environment and neural circuits and embryological function, and laser physics and how they influenced all of these things. And he chose the 1064 nanometer wavelength to deliver the sensations created through OraLase for a reason, and that is because it is unique in its ability to achieve a therapeutic depth of penetration without the risk of overheating the more superficial tissues. He chose the Photona delivery systems also for specific reasons, and those include the X-Pulse with the R26 handpiece and the modified tip and the connector fiber, and the Lightwalker AT or ATS with the R30 handpiece with a printed tip to help delivery, as well as sometimes the Genova handpiece. Combining the science-based yet nurturing aspects of the Miracle of Light with a nature-based approach to wellness is where Dr. Nordstrom began his journey in creating OraLase. And I was using OraLase for many years and many patients. And then one day I was pulled violently out of my comfort zone when a family came to my office at the suggestion of an infant feeding specialist, and they needed help with their little one because his feeding reflexes were not responding to any stimulus. He was on supplemental feeding tube. He was struggling to survive and had literally no gumption to be able to do anything. And they said, okay, we've seen what OraLase can do on adults, so we should be able to do this on babies too, right? And I said, I've never done this on babies. I never wanted to work on babies. I enjoy working on my adults and children. And I said, well, our baby's older brother, one shown in the picture on the left, had a similar presentation, and they did a surgical tongue tie release thinking it might be able to help him because he might just not be able to use his tongue. And he ended up in the PICU almost 2 weeks and almost didn't survive. We really don't want to go through that again. So can you offer us another solution? In addition to this mama and her baby, her sister and her mom came with her with another newborn baby that was high tone and structurally tied. And they said, we need help for both of these babies. And I was pulled violently, quickly into a place where I needed to make a decision. And as a mom with a baby who struggled, I decided to get out of my comfort zone. And that's where the magic happened. And that's the birth of BabyLase. And birthing this concept has not been easy. It's much easier to follow the leaders that tell us exactly what to do so we don't have to think about it. But what if what's out there right now only offers a partial perspective of the big picture? I've heard so many comments over the years, like, where's your research? And I kind of feel like David meeting Goliath in this field to bring this new concept forward. But my struggle with this is that the true definition of evidence-based medicine is really not appreciated by those who choose to ignore the limitations of research on humans. They hang their hat on a study and they just ride that horse all the way to town. And that's not necessarily fair to how actually science and medicine progress. There's been a lot of professional pushback, accusations that BabyLase needs FDA approval, which it does not because it's a technique, not a piece of equipment being sold. And because I am challenging some of what's being told in other tongue restriction courses, I actually have received cease and desist emails over sharing my message. And Brendan Stack told me years ago, you can always spot the pioneers by the arrows they have in their backs. This has not been easy. And one of the things that I talk about when I'm talking about primitive reflexes and the benefits and drawbacks of birth is that whoever designed the birth canal obviously didn't go through it because it's not an easy journey, but it is necessary and beautiful because after birth is growth, and growth is dynamic and it's amazing. And our community of OraLase and BabyLase providers is growing. Our curriculum that we offer is very, very concierge level. We have a lot of personalized training with very limited course sizes. And every OraLase provider and every BabyLase provider is encouraged to experience this for themselves to encourage their own personal professional growth. And the 100 monkey effect is something that we're coming up on this year as we train our 100th provider in a few months. It's a phenomenon at which a new behavior or idea is spread rapidly by unexplained means from one group to all related groups, regardless of the location, once a critical number is reached. So we're not going to give up. And someone is going to just be that monkey here in a few months for our OraLase and BabyLase providers. We're super happy about that. And we are much more interested in quality than quantity because we might not be the most popular, but we are really happy to be where we are. We're coming up and we're creating such value in lives of those that need it. So happy to be right now in third place with focusing on the ones who really deserve to hear our message. So what are OraLase and BabyLase? I'd like to bring some clarity to the confusion because there's a lot of confusion out there. We've had questions, where can I buy the BabyLase laser? What's the setting, which is not a setting, it's a sensation. Even key opinion leaders are saying the results are only temporary, which is only partly true. But when you put that in social media and act like an expert, it really kind of discourages others from thinking they want to learn more about it. There's been other people who have called our office saying, hey, I'm not a doctor, but I want to provide OraLase and BabyLase service to my patients and children. It's not possible. It needs to be operated by a doctor who can legally run a class 4 laser. And a lot of, hey, can you just show me a video? I don't want to have to take the course. I'm sure I could just watch a video, right? Because what's happened, because people thought they could do that, is the good old-fashioned telephone game and crazy misinterpretations of what OraLase and BabyLase are, because there's obviously a big difference between the innovators and the imitators. We like to be able to straighten up that confusion. I like to start by explaining that OraLase and BabyLase can be explained roughly to what we learned in basic life support with an AED, our automatic external defibrillator. When we have a bad rhythm, in this case, the analogy is a cardiac rhythm, we're assessed and a high dose of energy is sent into that system to be able to reset it. And we're doing this through laser therapies and light instead of the obvious electrical stimulation that is being provided with an AED. But when we're providing life support and we're using an AED in between these shocks, these reset sessions, the instructions are very clearly to keep the motion going in these tissues to be able to restore function. So we continue CPR. And in this analogy with OraLase, it's the manual therapies and the motor rehabilitation therapies. And then if someone cannot maintain their own rhythm and they need help, sometimes they need a pacemaker. And in this analogy, it's going to be the appropriate dental appliance therapy to provide the stimulation to keep that neural circuit going. What is OraLase? As I mentioned, it's a neurologic reset and integration. It allows us to turn on the lights of getting these neurons firing so that the brain and body can see each other under better circumstances. Kind of like the makeup after the breakup, because what trauma does is it turns these neural circuits off like a breaker box. It also allows us to adjust the dimmer switch. Say we have power, but it's just not enough. We can improve neural tone. We can integrate cranial nerves to enhance neurological midline awareness. We instantly relieve the restrictions associated with hyaluronic acid densification between the muscle and the fascia that have occurred from tissue damage and immobility. And until I became familiar with OraLase, I didn't even know that was another restriction. I felt it every time my muscles were sore. I really felt it when I got a deep tissue massage. I thought hyaluronic acid was just something I put on my face to help with my skincare. It's much more than that. In addition, we're increasing blood flow to allow the lactate in sore muscles impeded by this fascial restriction at the tissue level to mobilize. And we're activating mitochondrial function to create energy for cellular metabolism in the connective tissue, muscle, but most importantly, in the neurons. So a good analogy is to think about the Mr. Clean magic eraser. It's going to take away the pain, and then a magic wand that provides energy to the system. So once again, we take away the pain while turning on the brain. OraLase uses specific wavelength, intensity, and pulse shape in a sequence of strokes, predominantly in the oral facial regions, to create these unique, pleasurable, comfortable sensations that activate a very primitive response. It appears to release oxytocin, an open limbic window through which cortical memories can be coordinated with patterns in our cerebellum to allow old traumas, developmental inconsistencies, and a lot of frustrations from just efforting through life to complete nature's integrated processes. And these traumas and gaps would otherwise keep this limbic hypervigilance going, which is just that noise running in the background where our emotional system can't calm itself, which appears to be a common component in chronic disease. And the influence of these gaps created by trauma and the development of the oral facial zone can be related to Wheel of Fortune, where people are trying to guess, what is that puzzle? And I started looking through to find a good, funny, appropriate, Wheel of Fortune. And I found one that said, oh, don't get the tit bit in the pit. But my husband was sitting next to me, and he quickly realized that I needed an A instead of an I, because the real answer is don't let the cat out of the bag. But no matter how many times I do presentations using the slide, I still think about the tit getting bit in the pit, because that is the way I learned it the first time. and think about if there's a gap while someone is trying to develop a normal process, like learning how to support our airway during sleep, or learning how to calm our autonomic nervous system, or what we think about ourselves, or how to manage pain. If we did not have the A, but we have the I, we might not ever be able to solve this puzzle of what function truly is. All of these things profoundly influence oral facial growth and development, since all of the disturbances, the relationship errors, the neural circuits that weren't connected, they're going to affect us for the rest of our life. And the OraLase technique recognizes that the oral facial zone is central to how we integrate our lives, which is foundational for developing resilience. And that almost all of the critical maturational milestones happen before we can talk, and they involve touch and proprioception. So what is BabyLase? It's an adaptation of OraLase. This applies to the unique needs and challenges of our most vulnerable and adaptable ages 0 to 2. What BabyLase is doing is addressing the effects of birth trauma by normalizing the primitive reflex and cranial nerve system as its primary goal of treatment. We are improving neural tone for both the high tone or the hyper-responsive baby, we call them coming in hot, and the hypo-responsive low tone baby, we'll call them coming in not. And that was the 2 babies that I was tasked to treat very early in this process of developing BabyLase. We're also integrating cranial nerves to enhance the neurological midline and awareness for that midline with the baby. We're instantly relieving the hyaluronic acid restrictions, as we talked about with OraLase, and also increasing blood flow. And then we're increasing the mitochondrial function as well as what OraLase is. It's just a little bit different perspective. And we are on the cutting edge of not cutting. Both OraLase and BabyLase can be utilized to non-surgically and comfortably improve tongue function to assess if a tongue restriction needs to be surgically addressed, and when it should be, if it's necessary and appropriate. Allows the patient to gradually integrate the changes that are accomplished by simultaneously improving both form and function, and it promotes conservative care while utilizing an evidence-based approach to comprehensive wellness. And those comprehensive concepts are not just limited to what we can see under the tongue. It involves the entire function of the tongue, the orbicularis oris muscle, the buccinator, and the superopharyngeal constrictor, which is the only true ring of muscles and fascia that distalize the mandible. And that's kind of a big deal, because where the tongue goes, the airway is constricted. So getting the mandible forward will help overall function. And we do that by addressing the compensating muscles. We're also looking at the floor of the mouth musculature as a compensating muscle, as well as the masseter and the muscles of mastication. We use a comprehensive approach to care, which includes assessing and addressing the primitive reflex system, as well as the impact of adverse childhood events, the whole person, whole lifetime neurodevelopmental perspective, while addressing pain, sleep, facial development, and airway homeostasis from the very beginning of life, as well as the effects of limbic hypervigilance, which is that background noise of trauma, especially during infancy, because we can either learn it the easy way or the hard way. During this developmental process, there's interruptions, compensations, and adaptations. I like to help our little ones not have to have so many compensations so early in life. What OraLase and BabyLase do is they unlock a door to a window of opportunity, because treatment success is based on if a patient can find what they need on the other side of the door by identifying and treating all the restrictions that are impacting wellness and function. Those include oral facial myofunctional therapy or feeding therapy to strengthen the appropriate oral neuromusculature, body work to address fascial and skeletal issues, the improvement of resilience to address emotional traumas that prevent healing, and appropriate dental appliance therapy to maintain the neural circuits and the results of treatment. In other words, what OraLase is going to do is say, hey, we're going to open this door. We're going to provide all the neuromodulation, the fascial release, and then if you can find what you need, whatever therapy is really your problem, then you're going to be able to walk through that door and stay on the other side of it. If you don't, the door might close and you find yourself back to where you began, which is why we work with integrative teams. So when we open that door to a physical restriction release, as well as the neurologic connection opportunities that go along with it. The therapeutic window seems to be between 24 and 72 hours for most patients. And during that window of opportunity, we encourage the babies, the patients, the moms to be evaluated before treatment. So during the session, immediately after BabyLase or OraLase, that therapy provider can provide whatever they weren't able to do before because of the fascial and neurologic restriction has now been released and optimized with OraLase. And we have to be able to maintain those realistic expectations and time our treatment, keeping this very, very, very important concept of treatment in mind. In 2010, the American Heart Association revised what we were always taught was the appropriate way to be able to keep someone alive. And that was airway breathing compressions. And they said, you know what? We know more now. We're going to do better now. We're going to communicate that the most important thing to a human being is to get blood circulation to the brain to support the cerebral blood flow. And that includes not only oxygen, but nutrition. Then after we do that, we're going to assess for structural and non-structural airway carrying capacity restrictions. Yes, we always need to look at the airway, identify and remove any obstacle to breathing. And then we need to support the movement of breathing until the patient can do it for themselves. And that includes providing support for a more functional airway through neurological, mechanical, and metabolic assists. Because if we do not do that, a traumatic brain injury might happen, whether it's either micro or macro trauma. And those traumatic events derail neurological development. And what we're going to be doing is supporting that patient's ability to be resilient enough to overcome their obstacles by optimizing the limbic response, because brain dysfunction and intracranial inflammation can have long-standing implications. And think about how we learned about that with COVID. Understanding the implications of cranial vault mechanics is a big concept that a lot of us were not aware of through our traditional training. And then we also need to assess the effects of the injuries that do happen, assess them and rehabilitate them, and optimize neurological and fascial restrictions, especially prior to a surgical release, because that could be a pretty big injury. Regretfully, not all of these important concepts are covered in our traditional training. Those unaddressed influences include trauma, physical or emotional for the patient, the provider, or the parent, the importance of cranial nerve balance, proprioception, primitive reflex system, the impact of adverse childhood events, especially in the first 1,000 days of life, the importance of stage 3 sleep, the hyaluronic acid interface, and the role of that interface between the genioglossus and the deep fascia, especially if it's obliterated secondary to cutting the epimysium during surgical interventions to address tongue and lip ties. Emerging science is pointing the direction for our future to include the impact of trauma and potential effects on neurotransmitter depletion and sudden infant death syndrome, as well as sleep apnea, the role of inflammation and its relevance to sleep disorder breathing, and the influence of trigeminal afferents in neurological function and global compensations, as well as symptom expression for those compensations. Because the impact of early neurological development is a big deal. If we're knocked offline early in life, our limbic system, autonomic nervous system development, our ability to be plastic affect all of these different things as we go through life. Preconception, in utero, as we're an infant, and during childhood. When you think about it, what is our common denominator as humans? Our operating system, Mac or Windows, whatever it is, it's neurology. And think about if we had a server closet and we walked in there because our computer wasn't recognizing our server, would we go in there and just start cutting wires? Or would we try to figure out what's wrong and plug them back in? Think about what if this tongue is not neurologically connected to the brain in ways that are supporting its best function. And what if our common goals as healthcare providers could all be explained and connected through the understanding that the requirement of our brains and bodies needing to be working together with synergy is very important. And what if we committed to applying this knowledge using the techniques and technologies that are literally at our fingertips? The definition of synergy is when an interaction of elements produces an effect that is greater than the effect that would have resulted from simply adding up the effects of each individual element. And think about the synergy we can have if we had our neural circuits, our fascia, our tongue, and our craniofacial development all working together for the benefit of the patient. By providing an opportunity to address the potential origins of the disconnection between the brain and the body, we can strive to reconnect them. So we can address both the chicken and the egg and the cycle of dysfunction and the circle of life. Because when we understand that the conservative therapies that are based on nature of OraLase and BabyLase can offer solutions to aim to address tongue function, neurological function, fascial function, some of these conditions that have been continuing to challenge our healthcare system, and how that eventually affects the dental expression and the airway expression. The book, The 5 Love Languages by Gary Chapman, talks about how everyone has a primary language, and we need to speak that language to be able to fill that love tank for that person. But if that love tank in Gary Chapman's book has a hole in the bottom of it, we can fill it up from the top as much as we want, say the right words, buy the gifts, but it doesn't matter if there's dysfunction that is leading all of those good things right out the bottom of that tank. I want to think about that when we're assessing our patients, because if we continue to provide therapies, but they're not getting better, there's a dysfunction that hasn't been identified and addressed. And what the Academy of Breastfeeding Medicine came out with is a position statement saying that some of these babies are not getting better. We're putting all the therapies into them, but they're not getting better. So they said there's an ongoing need for high quality research in these areas because we need to understand what a tongue tie is. How deep do we go? What tool do we use? How do we document it? And what are the long-term implications? And this quote, I love it because it's not even related to tongue-tied discussions, but yet it is. I prefer tongue-tied knowledge to ignorant loquacity. We need to know more because there are many types of oral restrictions that affect oral function, including reflex patterning that is inappropriate, including the undeveloped suck, swallow, breathe reflex for premature babies, fear paralysis reflex, and Moro reflex, which are in utero reflexes, root, gag, lateralization, phasic bite, and palmar grasp, all which should be assessed in a baby when doing feeding therapy and tongue tie releases. The hyaluronic acid that is gluing the fascia to the muscle underneath it through densification of that material. Unresolved cranial, especially unresolved upper cervical spine rotations, secondary to what happens inside the womb and during birth, and restrictive and inelastic labial and lingual frenulae that do need to be addressed. And I like to have a discussion about how we might think about redefining a restriction. If you're sitting in an intersection and car number 1 is sitting there and the light turns green, but the car doesn't move. If you're in car number 2, 3, 4, you still have a restriction because car number 1 is not moving. In this analogy, think about that as neurological function. It is the primary driver of our function as human beings. And the neurology directly affects the fascia. And car number 2 comes along. And if we have a retained primitive reflex that is causing our fascia to be restricted because we're stuck in the startle response, it's not going to move. And if the fascia doesn't move, card number 3, which is the tongue, it doesn't move either. And we have low tongue posture and fascial restrictions that are commonly misidentified as a tongue tie, as Dr. Mill's research showed. And then if the tongue is not moving and is not elevating to the roof of the mouth with a proper mature swallow, we're not going to get proper development of the cranial vault, and that includes the maxilla and the mandible, but not only the maxilla and the mandible. All these are tied together. So the cranial vault mechanics are like a bus, and the pretty little white things that we all learned about in dental school, they're just the passengers on that bus. They're along for the ride behind car numbers 1, 2, 3, and riding along at bus number 4. So let's talk about car number 1 for a moment. In neurology, we have autonomic nervous system signaling and what our brain needs more than anything else, which is cerebral function. We have the retained primitive reflexes the impact of all of these things I'm getting ready to say with these big words that everyone's eyes are going to roll back in their head for a minute, but I want you to listen because you're going to have this explained in more detail in a moment. The mesencephalic trigeminal nucleus, as it's been linked to the etiology of sleep apnea. The locus coeruleus, as it affects our roles as dentists on every human being that walks in our office, whether we're aware of it or not. And that pesky trigeminal cardiac reflex, which is commonly misdiagnosed as sleep apnea. We have cranial nerve dysfunction, all of which can have a neurological stress response that results in tight fascia. And the fascia runs from the tongue to the toes and everything in between. And if there's a functional asymmetry in that fascia, it's even more complex. And then we have part number 3, which is composed of fascia on the floor of the mouth and the tongue. So the tongue function is directly influenced by fascia, and that includes swallow function. And there's also a lot of sublingual anatomical considerations underneath that tongue affecting the motion of the cranial vault, the airway, and the teeth riding along the passengers, which is obviously what most of us are most familiar with, which is dental expansion and airway related therapies. But we need to keep in mind the oropharyngeal airway is only one component of the cerebral oxygenation process. So we need to keep that in mind when we're just thinking about airway. And let's think about back to that car analogy and the traffic analogy. If you have a car that's going in the wrong direction at a high rate of speed, it should probably slow down before turning a corner, correct? Similar concepts apply in a patient's ability to adapt to a sudden surgical intervention, which is why we always recommend oral facial myofunctional therapy prior to and after a tongue tie release, but not everyone in the world is doing it that way. Some of them are just a slash and dash in getting it done. But keep in mind that swallow function begins at approximately 4 weeks of gestation. And if there has been a structural restriction that entire time, a motor engram has been well established. And anyone who's worked out on an elliptical machine and gets off the elliptical machine and tries to walk, quote, normally for a while realizes that there's a motor engram been established. Our legs still want to lift up. The motor engram of a swallow is still established. So making a drastic and sudden turn through a surgical tongue tie release may result in success if that patient is resilient and can turn that corner, or it may end in disaster. The system is rigid, or that baby or human doesn't possess the skill to adapt and reestablish a new pattern. In principle, a surgical release of restricted oral tissues under tension of a fascial restriction, sublingually, will provide an inferior result compared to one that is done with a tissue glide optimized by OraLase and BabyLase through mobility, as well as upgraded neurological regulation. We're taking off the brakes. We're turning on the lights. We're letting that system be as good as it can before we change it forever. And the irony of what a lot of us have been trained to do with the cave exercise, also known as the posterior palatal seal, is that I took the IAOM, myofunctional therapy course, and I sat there for 2 days and could not do a cave. I tried for years before that to do a cave. I wanted to. I'm an overachiever a little bit. I tried, but I couldn't do it until I had OraLase done on me. And 5 minutes later, I went into a cave and I've been able to maintain it because I had another restriction preventing that motion. It wasn't my lack of effort. It was my lack of ability based on a restriction that I didn't have help with until OraLase helped me. And spoiler alert, what is supposed to make us feel better with this K, which is everyone's goal, right? Might actually be making us feel worse. I know it did for me for 2 days while I was frustrated and sore. Then they did research. And they did research on a group of participants, which were about half female, half male. And they had 3 protocols where they asked patients to have just a baseline wherever their tongue is. And then they had tongue placement on the floor of the mouth and tongue placement on the palate. And what they showed is that the patients who put their tongue on their roof of their mouth, on their palate, had negative impact. So basically, the instructions to place the tongue on the roof of the mouth are not instructions that will promote reduced physiological function, in other words, relaxations, but they promote small and potentially important increases in overall activity as indexed by muscle tone and cardiac function. So when someone has a low heart rate variability, it indicates stress, physiological stress. And that's what they found out, that forcing a high tongue posture created low heart rate variability and we're stressing people out. So based on that study, what if some patients actually find a sense of calm through maintaining a low tongue posture? And what if by repeatedly forcing the tongue from its comfortable low tongue posture through habituated oral exercises, we might be creating emotional and physiological stress for some patients? And what if through the use of the floor mouth musculature to inefficiently elevate the tongue, if they have a compensation for swallow dysfunction because they just can't do it the way they want to do it, like I couldn't? What if we're creating pain? And what if we're creating a hyaluronic acid restriction and lactate through improper and excessive use of the inappropriate musculature? And what if part of the success attributed to a structural tongue tie release is through the creation of a quote neural hack, where we're kind of hot wiring the system instead of allowing that patient to find the keys to a more sustainable swallowing pattern through neurological and fascial integration. So think about it. We go in there and we cut the connectivity, like going into the server closet and cutting the wires. Have to figure it out, right? Have to start plugging things in. There's always a honeymoon period after any surgical intervention, any, even dental appliance intervention, because it's a change. So we get dopamine release and we get growth factor release to help us overcome the injury. And what if that creation of a more suggestible system by weakening the existing motor engram, taking it away and say, okay, I got to figure it out, but it's through punishment and avoidance instead of through play or interaction? What if it may be efficient to get it done that way in the short term, but maybe not in the long term, because it's much easier to find your keys than it is to hotwire your car? Think about how we gain control over this big, beautiful animal, the horse. We inflict pain and restriction in the oral, the trigeminal region. Also think about how we gained influence over other human beings through time, through fascial damage, basically. It made them more suggestible. They didn't want to get hurt anymore. So they just said, fine, I'll do whatever you want me to do. Please don't hurt me again. So let's discuss the methods and goals of treatment of lingual frenectomies when we're trying to get better swallow function. Is it possible in some cases that surgical interventions might create an environment for compliance without conversion to a more favorable and functional swallowing pattern that can sustain someone neurologically and structurally? So let's go back to the car analogy in the traffic jam. Think about car number one as neural circuits. This research shows that this is actually how our neurons communicate, is with light, back to the laser. So we're using photons and neurons to shape the field of neural stimulation and neuromodulation. God said there was light, and it was good. Let's consider the primitive reflex system as part of that neurological system and cranial nerve stimulation. I'm going to go over in a moment how important the neural reflexive nature of swallow and airway is, the trigeminal influences as it goes through the locus coeruleus that I mentioned earlier, and the trigeminal nerve influences through the sleep pathways that came out in 2023, as well as the influence of trauma on neurological development. The primitive reflexes are intended to be protective. They're there to be able to keep us safe. However, if they're not appropriately expressed, turned on or turned off on schedule, they can impede an ideal function and result in the death of brain cells. Those same brain cells are responsible for our proper neurological development. Fear paralysis reflex is in utero, turns into Moro at about 4 months. Moro's a startle reflex. It's supposed to go away at 4 months. When you startle a baby, their arms spread out and they curl up into the quote fetal position. That's Moro. About half my course participants, when we test them for Moro, have a retained Moro reflex. It's creating tension, creating neck aches, creating tongue restrictions, and a posterior tongue tie is the common phrase that is used to express that with low tongue posture. There's the root reflex, where a baby's supposed to root to be able to find the breast. Palmar reflex, the suck reflex, and the gag response all are supposed to be happening. If they're not happening, and the little boy that I was asked to treat had none of these going on when they were supposed to be appropriate, and therefore he couldn't eat. But guess what? After about 3 BabyLase sessions, he could, because this is what we were addressing. It wasn't the tongue tie. It was the tongue connection to the brain. The gateway to the reflexive system is the moral reflex. So the moral reflex is designed to protect us when we are vulnerable. But at about 4 months of age, we're supposed to be safe and start using those as postural reflexes. But when we do not feel safe, we're going to have a state of rigidity, that baby that throws its arms out and it shakes, and everyone thinks it's kind of funny, but it's actually pretty normal. That is what babies are supposed to do. But that constant activation of extension in an adult who has a retained moral reflex creates tension throughout the body through the activation of the fascial system. It could also be our kids that are being misdiagnosed with attention deficit disorder. So a lot of things that are being misdiagnosed that could actually be attributed to the retained primitive reflex system, especially moral. How to assess moral is to have the patient go into full extension and then to do a crisscross. If it's opposite side, left arm on top, right leg on top, that's an active moral reflex. How to treat is you have them practice doing the same side on top and then switching side. And the invisible influence of that moral reflex is fascial restriction throughout the body. And imagine you having a moral reflex that you're constantly being startled and you do not feel safe. Think about it as like this Facebook meme that I found. It says, my mind is like my internet browser. I have 19 tabs open, 3 are frozen, and I have no idea where the music is coming from. I think that's happened to all of us at some point in our life with the actual computer. But imagine that music inside of our brain is a trauma that activated the moral reflex, that's activating our fascia, that's keeping us tight, and is keeping our emergency brake on where we just can't go through life as gracefully as we like to. Think about our brainstem as a circuit breaker box. We have 12 cranial nerves, right? It's a critical aspect of a comprehensive approach to treatment of craniofacial dysfunction. And if we're not assessing it, we don't know what we're not treating. Think about the tongue, also known as my frenemy, also known as tonguezilla. In dental school, I just wish that I could have removed it and not had to deal with it. And now, 30 years later, I'm realizing that it is the key to success in life. We have 5 cranial nerves at the tongue moving at midline, 1,500 to 2,000 times a day. And that tongue could be what is considered to be an airway obstruction for some people. And so everyone's like, hey, let's fix that structural restriction. Let's get that airway open. But guess what? Airway function is neuroreflexive. And the size of that airway is actually secondary to the science that's coming out. So this study took groups of humans, all of which had narrow airways upon CBCT analysis. And they found out that the ones that were healthy could actually dilate their airway during inspiration, but the ones with sleep apnea could not. Keep in mind, it's not the size. They both had small airways. One of them has neural control, the other does not. That's a neural circuit problem. And this is what the Andersoni's came out with this year, or this past year. They said that despite its name, obstructive sleep apnea is not caused by an airway obstruction that prevents breathing. They concluded the dysfunctional mesencephalic trigeminal, remember the dental nerve, trigeminal nucleus, may be incapable of activating the neurons in the ascending reticular activating system, which guides our wake-sleep states, notably to those of the parabrachial nucleus, and this will ultimately lead to sleep apnea. And they hypothesized that obstructive sleep apnea may also be the result of ascending reticular activating system neurotransmitter deficiency. So our goal through OraLase and BabyLase is neuromodulation, to connect the neural circuits, remove the fascial restrictions, and pave the pathways to reduce both pain and inflammation and improve craniofacial pain and sleep disorder breathing, as well as to help to influence the effects of neurotransmitter depletion. Think about this picture on the left. Did that bird bend that fence? It should have been that one too, then. Correlation does not imply causation. Just because we have a small airway does not mean that we are not going to be able to sustain our breathing. Let's think about the potential explanations and solutions for that. So if oral function affects sleep architecture, we know that it does, but not just through a collapsed airway. And we've been told for about 1,000,000 years now, I think, that we clenched open our airway, but the Androsani study said, no, you do not. It said that we do not clench to open our airway. They're saying that the clenching that we're doing with rhythmic mascatory muscle action is actually causing neurotransmitter depletion, and that is causing sleep apnea. It's depleting the glutamate stores. Bruxism is leading to sleep apnea, but we're not clenching to open our airway. We clench and then our airway closes. What if we might be covering up the symptoms of an underlying dysfunctional neural circuit with trigeminally mediated compensations? And that's where we can help as dentists with OraLase and BabyLase. And for also 1,000,000 years, we've been told there is no I in team, right? But look closely. There is an I in team. It's in the a-hole. Somehow, dentistry has been misled to think if we only focused on the size of the tube that carries the air, that we didn't really need to look at anything else. However, it's been right under our nose, literally, pun intended, the entire time. The brain receives the blood flow as controlled by the autonomic nervous system, and largely the trigeminal system is highlighted in recent literature. So let's be integrative. Let's be aware of the limitations to the management of the structural aspects of airway when the research shows that we need to be looking beyond the airway and into the benefits of neuromodulation. Remember Captain Kirk? He said, space, the final frontier. Actually, neurology is the final frontier. In fact, remember Watson and Crick, the DNA guy? He said the brain is the last and grandest biological frontier, the most complex thing we have yet discovered in our universe. It contains hundreds of billions of cells and are linked through trillions of connections. The brain boggles the mind. Now follow that with Dr. Remmers in Dental Sleep Practice magazine. He said not every dentist, physician, or the ones that teach others appreciate the connections between airway and neurological factors. AHI then, or apnea-hypopnea index, then is a failure. It just doesn't take enough of the evidence that's come out since 2000 into account. So how can we neuromodulate? Let's be part of the solution, right? Be the change we want to see in the world. How can we improve patient responses to treatment? We can do that through mechanotransduction, which is touch, dental appliances, surgical, functional, and manual therapies. But then when you add optogenetics on top of it, using the 1064 nanometer laser therapies, we get highly efficient neuromodulation. Think of mechanotransduction, kind of like dial-up internet back in the day, and optogenetics is DSL. This research paper showed the benefits of electrical stimulation in cranial nerves and how it affects cognition and disease. And basically, as I said, they're using electrical stimulation. We're using a light-based pathway, but similar things could be extrapolated. Therefore, cranial nerves are special targets for neuromodulation, accessible near the surface of the body at direct afference to the cerebrum, conceptually axons the brain extending to the skin. And leveraging the features of cranial nerve stimulation allows us to treat a constellation of brain regions that is in line with modern neuroscience. And this is what evidence-based medicine really is. We are proposing through OraLase and BabyLase the same thing they proposed in this study, an intervention design framework based on driving cranial nerve pathways and targeted brain circuits, which are linked to specific higher cognitive processes. And we're doing that through the C-tactile fibers and their contributions. So we've all heard about the babies in the orphanages that were fed but didn't thrive until they were picked up and they were touched. We all need human touch. That's one of the things that OraLase and BabyLase do, is provide high levels of input through the C fibers. And what we've figured out, and we all know that we feel better when we get a hug, when we're touched by someone that we love. The brain over time, over evolution, has decided to take a very economic route, perceiving pain. It uses a single neural system to detect and feel pain, whether it's emotional or physical. So basically, they did research projects on people who just went through a breakup, and they showed them pictures of their recently broken up partner after one group had non-steroidal anti-inflammatories to treat physical pain. and the other one did not. And the people who had the NSAIDs actually recovered from their emotional pain better. Not that I'm advocating chronic use of NSAIDs every time we're upset. I'm just saying that that's demonstrating the pathway. And that's important to understand what OraLase is doing. Because the limbic brain area, or we call her the amygdala, or Amy for short, it's an important brain center for the emotional affective dimension of pain and pain modulation. And it's not just the pain that we have, it's how we feel about our pain. The difference between hitting our nose on the wall when we don't know that it's there, oops, accident, or a loved one hitting us in the nose because we've been a bad little girl or boy and we deserve punishment for that. Big difference in how we perceive that injury to the nose. What OraLase is doing is using a sensation creation to help undo those boo-boos of the intimacy model. We're creating sensation in a very specific pathway. And just like in the Wizard of Oz, it's like the brain goes from black and white to technicolor. So it helps us overcome those boo-boos that we might have had earlier in life. And literally people can recall, or maybe not even recall, just overcome injuries where mom or dad punched them in the nose because they were a bad girl or boy. And they can move through it because now they're adults and they have a prefrontal cortex that can help them rationalize that. And just like the ruby slippers, where Dorothy's crutch to get through this journey, we all have the ability to overcome these obstacles that we have in life. Dorothy had the ability to get to Oz and back to Kansas, but she thought she needed the ruby slippers to do it. Some people do need OraLase, so think about OraLase and the laser that we have as those ruby slippers that can help someone get from where they are to where they want to go, and a gentle support for the journey. OraLase sequencing includes, first, using the intimacy model of when we want to get to know someone. First, we handshake, and then we might hold hands, and then we might touch face, and then we might kiss, and then we might explore more vulnerable, highly innervated mucosal tissue as the next part of intimacy, and then the kiss goodbye. That's one of the principles that OraLase is founded on. This is something that humans are familiar with. We use that to our advantage to unlock the sensitivities in our brain that will allow us to overcome that trauma. We also are using the homunculus model, as we all learn in dental school. And look how close the hands and the arms are to the face. We're turning on the lights in the brain one step at a time, going from least vulnerable to most vulnerable. And if anyone has ever sat down at a table and they tried to enjoy dinner with a table wobble, they realize that that is no fun. So we want to stabilize an asymmetry, correct? So as we're going through the OraLase sequence, we are also stabilizing the table wobble. We're creating symmetry in the trigeminal system. What they found out with this research article that we're just getting ready to talk about is that asymmetries in the trigeminal, as well as vestibular signals induced by malocclusion, are detrimental for performance, and correcting them. And in this research study, they did an occlusal correction by providing a partially edentulous patient with a partial denture and balancing the occlusion. And that improved cognitive performance affected the reversal of Alzheimer's disease, as well as improved cognitive performance in normal subjects. So by correcting an asymmetry in the trigeminal system, we're able to influence wellness in the entire body through the sequencing and OraLase. So let's strive to balance cranial nerve 5 because it's all connected. This is the research paper that talks about how the trigeminal inputs may improve cognitive function through the locus coeruleus. The locus coeruleus interacts with that same thing I talked about earlier with the androsanies. We're talking about awake states of the brain and how we keep ourselves from falling into sleep apnea, which is the ascending reticular activating system. So in the locus coeruleus pathway, it interacts while measuring balance in the trigeminal systems. And the control of that activity explains why input signals affect sensory, motor, and cognitive function and are effective in relieving the brain pathologies as a complementary approach to treating all kinds of conditions. This diagram shows the fascia, all the fascial planes, and this is a cross-section right at about the hyoid. And we can access all of these different fascial planes to be able to help that patient release restrictions. And we can also treat all of these cranial nerves through that neuromodulatory pathway that we mentioned earlier. So we have cranial nerve 7, 5, 9, 11, 10. Look at how they influence sucking, swallowing, and breathing. And has anyone ever tried to push on a door that they're supposed to pull open? Well, think about that as something we might be doing with a lot of our techniques that if we don't know what I just mentioned, it might be just easier to pull the door open. So we're going to keep it real for a moment and talk about how we assess these things. In our Alpha Evolution and RestoreLase courses, we teach our providers how to assess moral reflex. The stop assessment is a subjective test of pain where we're checking to see if the lateral pterygoid, the buccopharyngeal fascia, is a compensation for a swallow. The orbiculus oris as a compensation for a swallow, and the floor of the mouth are tender to indicate dysfunction and hyaluronic acid restriction. We also use a switch test to be able to see neurologically if the swallow is supporting the trigeminal neural circuit or the occlusion is or is not supporting the trigeminal neural circuit. And then the cluck and suck, also known as the cave, which is the posterior palatal seal, to assess if a patient has the strength and coordination to perform that task. Let's talk about who's living in card number 2, which is the fascia, right? Back in Schoolhouse Rock days, we all learned the head bone's connected to the neck bone, but regretfully, dentistry doesn't allow us to explore that as much as we could or should. But when you think about it, the stechos actually dissected the part of the body that we all threw away in gross anatomy. It's the fascia that holds us all together. And then Tom Myers has this anatomy train picture that describes that the tongue is connected to the toes and everything in between with fascia. And think about what trauma and pain actually is. What the stechos discovered is that the hyaluronic acid density that is supposed to be a sliding lubricant layer between the muscle and the fascia. If it is not able to move, it could be at the origin of many myofascial pains. So how do we interpret pain? You know, we have babies that are in pain, they can't tell us. We have children that are in pain that really don't even know what pain is, but our adults certainly do. And they become very emotional about their pain. And we interpret all of our pain through our limbic system. And a major source of that pain that many of us have not had the ability to address up until OraLase and BabyLase is fascial restrictions and the hyaluronic acid densifications. We could affect it, but it's a deep tissue massage. And if you're doing a deep massage under the tongue, you're no one's friend. It does not feel good to remove that restriction. So let's think about how can we modulate our response to that pain. Remember, not just our pain, it's how we feel about our pain. Through targeting the limbic system by addressing the fascial restriction. Because if we don't, we're going to avoid and we're going to compensate, and it's going to get into a whole body, whole lifetime event. This is a really nice drawing to show where hyaluronic acid lives between the deep fascia and into the muscle. Basically, what we're doing with OraLase, because the 1064 wavelength, its chromophore is oxyhemoglobin. We're down here activating the blood and the muscle tissue. That's heating up the muscle. What's happening then is this hyaluronic acid that used to be glue, preventing motion, turns into goo when that 1064 interacts with the oxyhemoglobin in the muscle to allow the movement to happen. So think about it. What is the part of the iceberg that sunk the Titanic? And what if neurology and fascial functions are some of the most impactful aspects of tongue function, and our provider community might be the ones that can do the release of that the most efficiently? Something to think about. All these scientists are looking at an elephant, wondering what it is that they're looking at. They're blindfolded. Is it a tusk? Is it a wing? Is it a wall? Is it a rope? Is it a tree trunk? What exactly is it that we're looking at? We're all looking at trying to help our patients feel better, but I think we need to look a little bit deeper below the surface to be able to find our answers. And then let's talk about car number 3. We're getting into more familiar territory where people are like, oh, thank God you're talking about something that I recognize. because these are the things that we see in our offices every day. We don't see hyaluronic acid. We don't see locus coeruleus. Actually, we do, but not like this. And the frenulum pendulum is swinging because everyone has started to look at tongues in different ways. Some of them say, I don't always talk about tongue tie, but when I do, I mention posterior tongue tie and lip ties often go together. Yeah, because a lot of it is fascial restrictions. Yes, it can be apoptosis. Yes, it can be development, but a lot of the times it's fascia, and you will not know that's a fascial restriction unless you try to release it with OraLase and BabyLase. And the New York Times became involved when some of these patients, babies, parents, were like, hey, I got my baby's tongue cut and it didn't get any better. In fact, it's worse. We've all seen them. We've probably all been responsible for being part of that journey. Anyone who's been around long enough to do tongue tie releases knows that they don't always improve. So where are we going to be when this pendulum swings? We still have so much to learn. Think about, once again, tonguezilla, tongue to toes, and tongue-brain connection. We have to be looking at every aspect of this. So let's bring together the hyaluronic acid drawing, where we have hyaluronic acid here and the deep fascia, and then we have fascia underneath the mucosa and the muscle underneath it. And now let's look at this study. This study was performed by raising fascial flaps and looking at the surface underneath it. And they found out that if the epimysium of the muscle was disrupted, the structure of the hyaluronic acid gliding, lubricating surface was obliterated. In other words, a scar, because scars are made of fascia. So if we had a tongue tie early in life and it was addressed, but the epimysium of the genioglossus was affected, we now have another restriction. So maybe we had one step back and then maybe another step back because we had a surgical procedure that affected the epimysium, because the hyaluronic acid glide is gone. Let's start looking at bus number 4, getting more familiar yet unfamiliar to people who don't understand the principles of osteopathy in the cranial field, of how these bones of the head actually move. I know that it would be easier for all of us if we didn't believe that, but that's not true. Temporal bone motion has been measured through intracranial ultrasound, and yes, it was on the multiple sclerosis population, but talk to any osteopath, most chiropractors, any body workers, and they will tell you that these bones actually do move, and they move by the tongue. So let's step back a little bit and start letting ourselves not be overwhelmed by all the science, because it's, there's a lot of it out there. There's so much of it is unfamiliar. It's irrefutable. And let's start bringing some practicality to these principles, because complexity is the enemy of execution. The top video is me doing BabyLase. The bottom video is after BabyLase, where this baby is just relaxed and kind of stoned. The photographer wouldn't even plan to film that, but he was actually so amazed by how calm that baby was that he decided to take a video of it. So BabyLase is a very easy procedure where we just use this very gentle, loving light, and we get in the mouth and release the restrictions that are sometimes the most impactful in feeding. As easy as it is to be overwhelmed, it's also easy to get addicted to the miracles that you'll witness and experience when you apply OraLase and BabyLase in your practices and lives, because there's so much more to learn. And there's such a tremendous community of providers to support the new providers coming on board, as well as a lot of support for our patients. Our community is proud of the consistent and reproducible results that we get with OraLase and BabyLase, while we understand the implications of that no two people are alike. What we're doing is creating connectivity with patients through objective assessments so we can share them with our healthcare community. What we're doing is we're optimizing the oral neuromusculature through improved tissue guide, improved range of motion. We're preventing unintentional scarring. We're enhancing our neurological connections, and we're having patients who feel empowered because they can actually do what they're being asked to do. They can say their R's when they haven't been able to say their R's before. They can swallow pills when they've not been able to swallow pills before. They're able to sing better when they weren't able to do that before. So many miracles every day in our practices with OraLase and BabyLase, including a simple little cave exercise. Treatment of the floor of the mouth area with OraLase and BabyLase is important. And that means we need to be intraoral, just not extraoral, which is why the Genova handpiece has its limitations. Because when we're treating intraorally, it allows the activation of the neurovasculature and the neuromusculature to visualize the dynamic functional improvements of tongue elevation in real time as hyaluronic acid turns from glue to goo. It improves access for identification of the inelastic fibers, which allows much more conservative surgical releases with much less postoperative discomfort. It is best accomplished by using a direct and intraoral approach using the 1064 and the improved delivery system. It creates immediate increases in range of motion, averaging about 30% increased range of motion with the posterior palatal seal exercise, while instantly integrating the trigeminal neural circuit so the brain and the tongue can connect. It accomplishes elimination or significant reduction of pain upon palpation during the treatment session. Things to know about OraLase and BabyLase include the following. There's opportunities to have an amazingly effective and efficient fascial release with the increased range of motion and the limbic response of endorphin, oxytocin, and endocannabinoid treatment responses. And not every person's going to have this, but we've had some people that say they feel like they had, basically a gummy or some kind of substance that would alter their state, including getting munchies and being very, very relaxed. And once a patient experiences this, they can return to that feeling whenever needed. And let's think about the endorphin release that we get through kissing. We're creating that similar sensation through OraLase by stimulation of the lips. The obstacles include the results may not be sustainable if there's an unidentified or unaddressed restriction that's not addressed during the therapy window of 24 to 72 hours on average. Also, another obstacle is sometimes that first kiss, that first OraLase experience is so great. And if they didn't do what they needed to do afterwards, they might not be able to get that back. So we explain all of this in much more depth in the training courses. Our goal is to help our providers know before they go. Applications of OraLase include diagnosis and treatment planning and sequencing. We're trying to figure out, does someone need a surgical tongue tie release and when they need a surgical tongue tie release? OraLase and BabyLase are used extensively in that thought process. If we know we need to do a surgical tongue tie release, we're getting that baby or child or adult ready for it with OraLase and BabyLase. It can actually be a replacement for lip and buccal restriction release because a lot of them are actually fascial, they're not structure. And yes, you can weaken it with a surgical procedure, but why not allow it and enable it through a fascial release? We're enhancing the neurological honeymoon following the quote wedding of any dental appliance insertion. So basically, when a patient and an appliance say, I do, the honeymoon of OraLase afterwards, immediately after insertion, really helps any dental appliance function better. OraLase allows for increased range of motion for mandibular advancement appliances of any kind, and it can complement the treatment of any form of therapy, including orofacial myofunctional therapy. We've had kids that have been in speech and language pathology treatment for a year and not able to do what they needed to do, and they have one OraLase session, and all of a sudden they can. It can complement body work because it relieves fascial restrictions that they are not able to get through. Mental health because of all the different limbic responses we get, occupational therapy for retained primitive reflex integration, and many, many more. And as we all know, there's a difference between a honeymoon and a marriage. So let's go back and revisit this concept. Why do surgical procedures sometimes get improvements, yet fail to get long-lasting, successful results? Once again, remember that dopamine, remember the honeymoon. We have an injury and it might last forever and it might turn into a marriage or it might not. But we're looking for sustainability, which is why we want to address all the restrictions and just not what we can see. So what's more sustainable, a honeymoon or a marriage? What do you want in your practice? I guess it depends what you're looking for. I'm in it for the marriage of patient and provider. I want to be able to be there for my patients. I want them to say, thank God that worked. I'm much better now. I don't have to come back to you and keep getting revisions and revisions and revisions and a new appliance. I'm looking to make them the best version of themselves. And if I can do it, you guys can do it. The Sinatra test. If I can make it there, if I can make it in New York, I can make it anywhere. I want you guys to be able to do this with all of your patients all of the time. And I know this information is not always the easiest to take in, but the dedicated provider has so much support, training wheels until you learn to be able to ride on your own. And we have providers in our community from all over the world with very grateful and empowered patients, and the momentum is building. Over time, I think medicine has kind of put dentistry in the corner, like baby. Like we've been put in the corner, and nobody should be baby in the corner. It's time for those of us who are ready to optimize the oral environment to rise to the occasion and literally have the time of our lives while bringing along our patients, our teams, our families, and our communities. We have an amazing community of providers and great support from Fatona. There are both online and hands-on training based on years of feedback and refinement of the level of service that we offer for our provider community. So we always really insist on the hands-on course, but after that, there's so much learning virtually that can be done. We're going above and beyond to utilize as many tools as we have available to help our patients through a comprehensive, gentle, and conservative approach to care based on both nature and nurture as supported by science. And we're absolutely honored to be changing the world one smile at a time. And we are on the cutting edge of not just cutting. Yes, we know that sometimes surgical releases are indicated, but we have more to us than that. And why compromise when you can first optimize? Because healing is a matter of time, but it's also a matter of opportunity. What OraLase and BabyLase are actually therapies. They're not like a one-time thing. They can be, but we never want to promise that. Mine was because I'd already done so much work to get ready for it and I knew how to maintain it. But our providers are trained to understand that healing is a process that requires persistence and patience and not to overpromise. And if I would have continued to look at the mass of babies out there that could have benefited from this, I wasn't going to do anything. But as Mother Teresa said, if I look at the mass, I will never act. If I look at the one, I will. I had this family in my office and needed my help. And I had to get out of my comfort zone and do it. And I'm forever grateful that I did. So to bring it full circle, when you ask why, what if, and why not, you force yourself to explore what's possible and not just what is. And it was possible. And what if it's possible for you too? What if a family like this one came to you for help and you held the key to their success? So thank you for listening and learning today. And I love this quote. With every course I teach, I say it. Never doubt that a small group of thoughtful, committed people can change the world. Indeed, it is the only thing that ever has. Every patient is a mystery, and every day is an adventure with OraLase and BabyLase. And I love this Dr. Seuss poem. You have brains in your head and feet in your shoes. You can steer yourself in any direction you choose. You're on your own and you know what you know, and you're the guy who'll decide where to go. Now you have access to the tools at your fingertips and the knowledge in your head. And those that are willing to take the next steps in this deeply personal and deeply thoughtful aspect of going the extra mile and caring for your patients are going to be such a gift to your life. I can't even acknowledge that with any more clarity than what this has brought to my life as a provider. I absolutely love my job. So thank you for helping all of our most vulnerable to become our most victorious. Feel free to contact me at any time at admin@thesynergy.academy. The resources available to you include babylase.com, oralase.com, and the Synergy Academy channel on YouTube. Thank you for listening.